Good evening. Welcome to the Lumbar Spine Research Society educational webinar. My name is Mike Lee. Tonight's topic is a debate, lumbar disc arthroplasty. Where are we in 2020? We have a phenomenal panel of speakers tonight, Dr. Hyun Bae from Cedar Sinai, Dr. Rick Geyer from Texas Back Institute, and Dr. Todd Albert from HSS. I really want to reserve our time for the presentations and the discussion because it's evening time and we're all kind of in our personal time. So I don't want to spend too much time on introductions, but it is truly without exaggeration when I say that these three speakers are among the most prominent thought leaders in spine surgery, technology, and in particular disc replacement. So I'd like to thank them all for being here tonight, sharing their time with us and their expertise and wisdom. I also want to thank the viewers for sharing your evening with us. This should be a lot of fun. We're looking forward to an exciting, educational, and entertaining discussion debate surrounding lumbar disc arthroplasty. Before we get started, just a couple of points, one point on housekeeping. For the viewers, if you have questions, please use the Q&A function on your Zoom. The three speakers will speak sequentially, and we'll reserve the time afterwards for discussion regarding the questions. We have allotted 1 hour of time, but we can go over depending on how the discussion goes. And we'll try to get to as many questions as we can. So without further delay, why don't we go ahead with the first speaker, Dr. Hyun Bae from Cedar Sinai, who will speak on the emergence and evolution of lumbar disc arthroplasty. Dr. Bae, if you could share your screen, we'll get started.
Okay, let's see if it works. There's always a moment where we're like, okay, is this going to work? Just want to say thank you for letting me be a part of this. I hope you guys can see my screen. Mike, you're going to tell me if you can't. Also, I want to thank Jason Cuellar, who was my previous fellow who helped me put these slides together. And so I'm going to talk about the emergence and evolution of disc replacement here in the US. And really, I want to kind of talk about why I think that we really haven't hit the renaissance for artificial disc, at least in the lumbar spine in the US, and what held us back. So obviously, you can't really talk about artificial disc replacement without giving some kudos to Sir John Charnley, who I think for orthopedic surgeons was really introduced us to the era of modern orthopedics. And this is low friction arthroplasty. And this was late 50s, 1960s. And at that time, there was a guy named Ulf Fernström who was putting stainless steel ball bearings into the spine. And this is always shown as a part of arthroplasty history. And what's amazing, I don't know if you ever knew this, but this actually came back later by Medtronic. They introduced this again back in the 2000s, where they again introduced ball bearings made of PEEK and stainless steel. And after about 4 years, they took them off the market due to subsidence. And so here's John Charnley. And obviously, you know, if he says in his quotes, I predict that hip fusions will be reserved for the only desperate cases, and arthroplasty is the wave of the future. And I think a lot of this, for us in spine, when we first introduced arthroplasty to spine, we thought that this would happen as well. So this is the young Todd Albert about 20 years ago, and this is his quote. Looks a lot like Charlton Heston. He's got hair. And he says, fusion is a gold standard with excellent long-term follow-up. Arthroplasty is unproven, unnecessary because my patients don't miss the motion. I predict that arthroplasty is a passing fad. We are more likely to see a woman or minority become the president of the United States and see arthroplasty become the dominant operation. And what I will say that a part of this is really true. You know, I do not think that, you know, obviously he's wrong in some ways, but arthroplasty certainly isn't the dominant operation that we once thought it would become. And so here is Ulf Fernström, and these are the x-rays. And I think that, you know, there's a myth that maybe JFK had one of these in his back. This is often shown when you look at the history. This is Kostrock's design. And I think they just show this because it's Kostrock, but in reality, when you look at this, I don't think any of us would think that this is a good design. But another forefather of spine surgery, I think Art Steffi was probably one of the forefathers of modern instrumentation for spine. This is the Acroflex disc, and not much is really written about it. People don't really know about it, but this was introduced in the late 1990s, early to late 1990s. And look at this disc. This disc is amazing. You know, when you look at this disc, this looks like a modern disc replacement today. Now, they had 100 patients, and somebody looked at their 10-year survival, and certainly there were subsidence, there were some traumatic failures, but the failures, I think, were really due to just the materials. It wasn't really the mechanical design. And I think, you know, if you replace this vulcanized rubber with more of a polycarbonate urethane material, this could have introduced us to the modern disc replacement back in the 90s. So you can't really talk about arthroplasty without bringing up the Charité. This is Charité Hospital. It's a teaching institution in Berlin. It's one of the largest, and they have 40 Nobel laureates to their credit. And Karen Boutner-Jans, who is an Olympic gold medalist, as well as Kurt Schellnack, invented a disc that was called the SV Charité after their names, Schellnack and Boutner-Jans. It was approved in the US on October 25th of 2004, and probably was the initiation of what I would call the disc replacement, at least idea of a rage. And this was kind of follow-up to the cage rage. And what was fascinating is J&J purchased the rights to this, and they paid $700 million. And they went out and tried to train 2,000 spine surgeons. That was their goal. And they probably ended up training about 1,000. Now, what happened to the Charité? Well, eventually it was removed off the market in 2012, but I don't really think it was a problem of training. There were some issues. People said, oh, they trained everybody on calf spines and it wasn't human spines. And you know, I really don't think that's true. The calf spine actually was pretty good as far as a training tool. It really, I think, was really the design. The design was very unconstrained, very small sweet spot. You know, you had to over distract to get past the spikes. Insertion wasn't easy. A lot of end plates were damaged to lead to subsidence. The device itself was unconstrained, so there was only a very narrow corridor of where you can make it work. And so I think this is really more of a design issue, but it was eventually taken off the market in 2012. And so I bring this up. This is Thierry Marnet, and he was the inventor of the ProDisc-L, and he initially planned 64 patients. And by the time the US IDE started in 2001, he had already had 10-year follow-up on his original design in 20 of those patients. And this was very, very impressive. And I think that's what kind of got our group into arthroplasty. And what's another fascinating thing is that in 2001 is when I started my practice. And so literally when I started my practice, this was September of 2001, in December, we had done the second lumbar ProDisc. The first lumbar ProDisc was done by the TBI guys over with Richard Geyer and Jack Ziegler. And we did the second. My partner was Rick Delamarter. So really the introduction to my spine career was really the introduction to arthroplasty for me. And so I kind of grew up in spine with arthroplasty. What's fascinating is that when I went to get my boards for orthopedic surgery, I had 3 cases of arthroplasty. And I was thinking to myself, oh my gosh, I am going to fail. I can't believe I did this. What was I thinking? But I managed to pass anyway. So the ProDisc got approved in August 4th of 2006. And you would think at this time that, you know, we have a very good artificial disc. I think what ProDisc did is brought some reliability, meaning that it was more constrained or semi-constrained. And the sweet spot for this disc was much greater. So, you know, you had a little bit more wiggle room. You didn't have to over distract. It was a nested design. So you put the poly in afterwards. So you really didn't have to fully distract. You could put the 2 end plates first and the poly would kind of slide in. And so that made a little bit easier insertion and allowed, I think, more people to put this in reliably. But this was the problem. Okay, so in 2009, if you looked at the lumbar arthroplasty market, it was about $20 million. And that really, really posed a problem because the analysts predicted when artificial disc came to the market that it would be between $300 and $1 billion. And because the economics did not make sense, we had this problem. This is kind of the valley of death. This is what I call the USA TDR junkyard. And not to say that these weren't great devices, they were amazing devices. And many of these devices actually eventually got FDA approval. FlexiCore, Maverick. You can see a very compliant disc called the Axiomed on the lower right-hand corner. That actually was born out of Cleveland. I know Izzy Lieberman, who's at TBI now, had a part of it. And that really, to me, looks like the Acroflex with just better materials, a lateral TDR, and the Kineflex. Now, there were issues with metal on metal because J&J had a large lawsuit with metal on metal hip arthroplasty. But really, I think the main issue was the market just could not support it. If you're looking at a $20 million market, how do people introduce something? Like how does Stryker introduce a artificial disc to a $20 million market? It just doesn't make sense. So it took a long, long time to get our next approval, okay? And that didn't happen since 2015 for a device to really be released to the market. And this is the activL. And so I would say the two major artificial discs currently in the US is the activL and the ProDisc-L. Okay, so those are the two in the US market. And you would think that maybe we should have more, but I think I've showed you the reason. And then finally, I think this probably slipped most radars. I mean, in April 15th of 2020, the FDA approved two-level ProDisc. So two adjacent level now has FDA approval. And why was this a new study? Actually, this wasn't a new study. When we started enrolling in the FDA trial back in 2001 for the ProDisc, it was actually a 1 and 2 level trial. And the data was already there. It was again the economics. Even though they had the data, they never went to the FDA to get the 2-level approval because the economics didn't justify it. You couldn't do it. There are a lot of problems as far as trying to get these approved. But finally, we do have 2-level approval at the FDA, but we do know that this probably does not matter. So these are my 5 top reasons for lumbar TDR failure in the USA. Okay, number 1 is insurance companies. Number 2 is insurance companies. Number 3 is insurance companies. Number 4 is indications, because there is some negativity to dealing with back pain. It's not cervical radiculopathy, which is a more straightforward indication. And then finally, it's training access surgeons, because you have to have a good access surgeon, whether that's a vascular surgeon or a general surgeon. And so that adds one more barrier to train. And so, those are the other reasons, but really the main reasons I'm going to tell you is insurance companies. Now, what we didn't realize that after getting FDA approval, it wasn't enough. It was actually the payer was the most important body to convince, and it wasn't the FDA. And we got some signs of it when CMS considered a non-coverage decision for arthroplasty, okay? I think once they gave that window, I think a lot of the payers kind of just jumped on board and said, okay, wait a minute, CMS is considering a non-coverage decision. They're not going to cover it for their patient population over 65. And I think that gave a little bit of leeway for the private insurers. And they kind of said, hey, we're not going to cover it either. How do they decide? They typically decide with these tech assessments. So every year or every 3 years, they'll review a technology. And that technology will be done by a board of people. And it just won't be, they'll buy a spine surgeon, they may have an orthopedic surgeon, but they'll have a pathologist, they'll have an internal medicine, they'll have a nurse. And these boards then look over the literature. They're supposed to be somewhat non-biased, and they decide whether the policy will change or not. And what's fascinating is that, artificial disc went through multiple tech assessments and really always had problems. So lumbar artificial disc, at one time, all these carriers had it declared as investigational and experimental, even though the FDA had already approved it. And really, this is what I think really helped the market. It truly was the lawyers. The lawyers helped this, the kind of lawyers to the rescue. This is a firm in Southern California that brought a class action suit against Blue Shield of California for its categorical denial for artificial disc. So there was an appeal process, but they categorically denied it. And to the face of their policy, they really didn't have the right, if it was generally acceptable and recognizable to professional medical standards of being safe and effective. And this is how they got him. So before this settled, Blue Cross settled out of court because they were afraid of the damages. And as a part of the settlement, they allowed artificial lumbar disc. And once Blue Shield, which is the biggest carrier in California, kind of did this, I think all the other carriers followed suit. So Blue Cross of California, National Blue Cross now has a coverage decision that artificial lumbar disc for one level is covered. United also now has a coverage decision that lumbar artificial disc is one level is covered. And the last one standing currently looks like it's Aetna. And so there is currently a class action suit against Aetna by the same firm to try to get lumbar arthroplasty covered. So this is only for single level, and we'll have to see how that'll apply now that the FDA has approved 2 levels. But I think this really has helped the most. It's really having the private payers now have a coverage policy and not declaring it investigational and experimental. And so future treatments. So I'm just going to show you some cases which I really think should be kind of the renaissance and how we may use artificial disc once we get more comfortable. Now, just to say, I've been using artificial disc since I started practice in 2001. So I've got 19 years of experience. And sometimes after you do something for 19 years, you get bored of doing the same thing over and over and you expand the indication. So I just want to say these are definitely expanded indications. These are not, straight by the FDA indications, but I think that probably makes more sense in some way. So here's a patient. This patient is 42 years old, chronic back pain for a long, long time. And now has debilitating leg pain and weakness as well, but significantly has a big component of his problem is really back pain. And, he goes around and he gets different opinions, and the different opinions are microdiscectomy or a 2-level front back fusion or a 3-level front back fusion. Okay. And if you really think about all those 3 indications, they're not terrible. I mean, it does make sense, even though we're talking about the same patient. And so this is his treatment, right? And, to me, this makes obviously more sense because I did this, but it's a way of treating this patient level by level, right? So if you believe there's a collapsed disc and it's causing back pain, you can do a fusion. It doesn't really have that much motion. If you want to preserve motion and you think that there may be some degenerative disc disease and back pain, why not do an arthroplasty? Treat it level by level. You don't have to do a posterior approach. It can all be done anteriorly. So these are some others in some cases that I think will show you some things that we may see in the future. This is a 59-year-old male, so definitely on the older part of the spectrum. He's got terrible back pain for a long, long history and now has buttock and leg pain on the left side as well. If you look at the facets, really aren't too bad. He's had a prior microdiscectomy on the right many years ago. And, this is what we do for him. We do an artificial disc. We are able to decompress just like we would do in the cervical spine for a cervical radiculopathy. We're able to do the same thing in the lumbar spine, distract his disc space and provide him similar doses. And this is what's amazing. If you really look at his full-length films prior, you can see that he has a degenerative, kind of decompensated spine. These are his parameters with lumbar load doses of 29 degrees and a PI-LL mismatch of about 22 degrees and an SVA of 9.4 centimeters forward. And this is how he looks like after just a 1-level artificial disc. And I'm not saying that the artificial disc is a deformity corrective device. It's not. And you could probably do the same thing with a 1-level fusion at L5S1 because we do know the lower down you get, the more low doses that you would get. But what I do think is something interesting. You're able to restore some lordosis, able to balance the spine better, but at least the lordosis is functional, meaning that it's not fixed. It's not fixed lordosis. This patient has functional lordosis. And in some kind of biomechanical way, I think that may be beneficial for the patient. Here is a 53-year-old male, 2010, who has this spondylolisthesis at L4 or 5. I didn't do his prior surgery, but he gets a 2-level fusion, TLIF, which I think is quite reasonable. Yes, the pedicle screws were not in the pedicles at L4, and he did have a pseudoarthrosis. But his pain, he kind of learned to live with the pseudoarthrosis and his low back pain. He presents now at 61. He's 2018, and he has degenerative disc disease at 2-3. And his upper back pain or his mid back pain is really what's keeping him from being active. And he's a marathon runner. And so this is kind of what I would say. I mean, I'm not sure how I would treat that otherwise if I really wanted to treat the degenerative disc disease at 2-3. If I fuse 2-3, I'd be worried about 3-4. I may want to fuse 3-4. I may have said, okay, you need a T10 in the pelvis. But I think this result, may be another option for him. And I think this is what we may see in the future if we can really utilize this technology reasonably. And then finally, I just feel like I'm the opening act for the great master debaters who are coming next. I would say, get ready to rumble, lumbar ADR versus fusion. Thank you very much.
Great. Thank you, Dr. Bae. That was fantastic.
All right.
Next
Go ahead,
speaker is Dr. Rick Geyer from Texas Back Institute, who will present the argument in favor of lumbar disc arthroplasty. Lumbar disc arthroplasty continues to play an important role in spine care in 2020. Dr. Geyer, are you able to share your screen?
It says cannot start sharing while other participant is sharing. So you need to unshare.
Okay, gotcha. Done.
Okay. We are going to be up, and can everybody see my screen?
Yes.
Okay, great. Well,
Yes.
Thank you, Mike, and thanks for inviting me. This is always a lot of fun. And Bae, thank you. I was a little worried that we would have a little bit of, or a little bit too much overlap, but we didn't. So here are my disclosures. And just as a way of history, I want to tell you that Todd and I had debated the same topic in 2006. And, isn't this old news already? So 14 years have passed, and are we tired of it yet? And after 6 months of COVID, we're all tired of it. But I have to disclose that Todd and I have a very, very special bond, and only he and I know about this, that was made on our way to a meeting for the Brazilian Spine Society in Gramado, which is like their chocolate capital. And that was in 2007. Right, JB? Now, you can't ask me about JB, but he's smiling. Anyway, so yet a motion preservation alternative to functionally limiting low back pain is still being debated despite all the great data. So I did my research. I went to Google and I looked up Todd Albert, does he do lumbar disc replacement? I found 826,000 citations, Todd. You are so freaking famous, I cannot believe it. But yet not a single one mentioned that anything about you and lumbar disc replacement. Now, in all fairness, I did the same for me, and I only had 480,000 citations, so I feel a little bad. But the first three mention disc replacement. So I'm going to be gentle. In 2020, as Bae gave a great introduction, would you offer a patient that had severe degenerative arthritis of the hip a fusion? Well, the answer is of course not, when we have a proven alternative. And if we look at the history of spine surgery, it was in 1911 when the very first spine fusion was described by Hibbs, and we had the first discectomy, and then we had 89 years of the tradition of fusions, all the various kinds of fusions, unmarred by progress until finally artificial disc replacement was introduced to the US in 2000. So the question is, and Bae showed some nice pictures, would you rather have your pictures on the left, or would you rather have the one on the right with the fusion if you were, one of us? And we know that motion is better. And the top is a patient of mine that I did a 3-level on about 4 years ago. He has zero pain. He's playing golf. He plays with his kids, but he was miserable. And on the series of pictures down below, we see what is all too common. The first picture on the left, already the patient had a morphine pump, had a TLIF, and was now breaking down the next level. So they extend the fusion one time, and then they go up again, and they're going into the pelvis. So this is something that we see all too often. Now, Bae alluded to this as well. And in many cases, sagittal realignment can be restored by letting the patient find their own natural balance, as you can see with this patient of mine. Now, I didn't measure his parameters. I can't say they're perfect, but clearly they're better than what he had. And Bae went over this a little bit. Basically, the ADR designs were pretty simple. They tried to fashion them after total hips and total knees, and they were ball and socket. Some had a sliding polyethylene core, and then there came about the one-piece viscoelastic. And I like your boneyard or graveyard of all the different artificial discs, but only the ones in blue were approved, and Bae talked about how the Charité was taken off. So we basically have the ProDisc 1 and 2 level, and we have the activL, the only two that are available today. Outside the US, they also have third generation, the M6 and the LPESP that is very, very popular abroad. So not to belabor this, they talked about this. The SB Charité was developed at Berlin Hospital and was first introduced in the US, and the first disc replacement IDE was started with my partner Scott Blumenthal doing the very first one at TBI in March of 2000. So we've been doing disc replacement now for 20 and a half years basically. And then of course the ProDisc he talked about, that was developed by Terry Marnay, and we did the first one at TBI, and then Rick Delamar did the second one, and it was approved in 2006. And if we look at the history for lumbar surgery for degenerative disc disease pre-2000, there wasn't really strong level 1 data to justify any procedure we did for low back pain. And in fact, many prominent surgeons felt there was no value to doing fusions for low back pain. And you can see listed the number of studies that were published on doing surgery for low back pain. And it was really a very, very small number. But that all changed in 2000 with the FDA PMA studies, because the artificial discs were class 3 novel technology. They required a multi-center prospective randomized controlled trials with the fusions as controls initially, and then later they were disc-to-disc studies. These patients were carefully selected with strict inclusion and exclusion criteria. We followed specific guidelines in data collection, and we collected the same data for the fusion control as well as for the investigational arthroplasty. So finally, we had some good science behind doing surgery for degenerative disc disease. And the outcomes of the ADR have exceeded our expectations with long-term published data. The only disappointing thing, as Bae said, is the adoption overall. We see that the arthroplasty publications from 2000 to 2017 have increased significantly. The lumbar artificial disc, not as much as the cervical as we see here in the 2017. There have been, the 2 randomized controlled trials with 2-year data that were published by Scott Blumenthal and Jack Ziegler, both from my group in 2005 and 2007. And then I was the author of the 5-year Charité study that showed basically no change between the anterior interbody fusions and the artificial disc between 2 and 5 years. They had a greater return to work with fewer patients on long-term disability. We see similar 5-year results published for the ProDisc 1 level, and showing that both groups, the fusion, which was a 360 for their control, improved and maintained the improvement, but also so did the fusion patients between 24 and 60 months. And then the 2-level study, which was completed actually and published in 2011, and it was really through a series of events, and it was more economic why the company didn't push through the approval. But finally, in the spring of 2020, the 2-year, as Bae said, was finally approved by the FDA. And then the activL, which is the most recent disc that now we have. So we have the ProDisc and the activL, and this was approved in 2015. And we see, because this was the first disc-to-disc procedure compared to the ProDisc as well as the Charité, although these numbers are only showing ProDisc, basically there was no difference between the 2 discs at 5 years in terms of the VAS and the ODIs. And if you look at the evidence for degenerative disc disease, there have been 5 randomized controlled trials with 5-year follow-up. Only one of these were outside the US, and that was done in Sweden, and they compared multiple discs. But all the others were in the US and had 5-year follow-up. And Jack Ziegler and Matt Gornet had done a meta-analysis of the 4 IDE studies that had 5-year follow-up. And the meta-analysis of RCTs is really considered to be level 1A evidence. That's the highest level of evidence. It increased the statistical power of all the studies and decreased the confidence intervals, allowing for great accuracy and allowing for the population effect size. And what they found, looking on these forest plots at 5 years, that the ODI success favored the TDR, reoperation rate favored the TDR, which means it had less, and the VAS score for pain favored the TDR. So the pooling of data increases the power to detect significance, which may not be seen at 5 years in some individual RCTs. This was some preliminary data that we had from TBI. We presented this at NAS, and this was a 10-year follow-up of our ProDisc versus fusion patients. And you can see both did fairly well out to 10 years with significant increases over their pre-op compared to their 10-year follow-ups. And if we look at the question of ASD, because that's always been an issue, you know, we felt that if you maintain motion, you biomechanically should put decreased stress, but it's always been the argument between genetics and is it really the mechanical stress. But in this study from the ProDisc versus the 360, they found that 28% of the fusion patients above the level of the fusion had radiographic changes, where only 9.2% of the disc replacement patients had changes, for a 3-to-1 difference and a p-value of 0.01. If we look at the again, the radiographic adjacent segment disease with the activL study, we found that basically the greater the range of motion was, the less likelihood that there was any chance of having adjacent segment radiographic changes. So if you didn't have any range of motion or a fusion, you had nearly 11%. If you had greater than 5 degrees, it was about 1.1%. And if we look at the range of motion of all the discs that reported 5 years, whether they were approved or not in the US, we see that they all maintain their motion. So the other concern we had, were they going to maintain the motion, or were they going to get heterotopic bone and lose their motion with time? If we look at the reoperation rate from the activL study, we see that there's a 95% chance at 5 years that the activL patients wouldn't have had any additional surgery. And this is compared to the controls, which is about 90%. So it wasn't quite statistically significant, but nonetheless numerically showed that it was a little bit better, but not statistically. And if we look at the early data from the ProDisc, for the first 1,000 ProDisc-L cases post-approval, there's only a 0.3% revision rate. And of the first 1,300 ProDisc surgeons that were trained from 2006 to 2013, there's less than a 1% revision rate. So everybody predicted that there'd be a horrible revisions, we're going to have deaths, we're going to have all sorts of horrible things. Well, we looked at our own data, and we looked at our first 1,700 patients over a 17-year period. And what we found was that we had 17 cases, or 1%, and 9 out of those 17 occurred within the first 25 cases of each of us. In other words, that was our learning curve, and we tested 6 different lumbar artificial discs. So the other 8 occurred at later dates. So one of our good friends, Matthew Scott Young, published a study on hybrid, and Bae showed a picture of a hybrid. And this is also another nice technique. And it's also a nice technique if a patient has a fusion at L5-S1 and you want to do an artificial disc at the level above. And we've all seen many patients like that. So his follow-up was about 36 months, and but the range went out to 96 and had significant improvement in back pain, leg pain, and ODI. And because of the ALIF and TDRs, and Bae knows in the West Coast, and particularly in the Southwest and South, they've become so popular in certain areas that there has been a new society for anterior access surgeons, because the predicted disasters and death from revision surgery never materialize. But the general surgeons realize this is a very easy life for them. You know, so they just come in, see the patient in surgery, do this access for us, and then they leave and they get paid. But most of the revisions that we do for failed disc, and there's not many, are done posteriorly. But L5-S1 can be easily revised anteriorly with an excellent access surgeon. Above L5-S1, it is doable, but you really need an experienced access surgeon. And usually it is reserved only for those displaced implants or infected cases. Again, extremely rare, less than 1%. So what about the economics? Well, there's been more than 6 published studies, and I had the only study that showed that fusion was less expensive, but that was only if you took the patient's iliac crest graft. So despite all these improved, value statements with respect to TDR with improved function, earlier return to work, etc., there's still the denial, as Bae said, by some insurers invoking the experimental excuse. But he also pointed out that it's getting better. And as of 2020, now there's 76% of covered lives can now get the artificial disc. Aetna is the last holdout. Once they fall in, it will be close to 95%. So where are we now? Well, we have more than 30 years experience with lumbar disc replacement and fewer years with cervical and greater than 35 years with fusions, at least at TBI. The literature search for lumbar and cervical disc yielded over 1,000 articles, and in no other area of spine that has been scrutinized so extensively and by so many FDA trials. So where do we go from here? Well, we're going to have better diagnosis, because a lot of people say that, how do I know this is where the patient's pain is coming from? MR spectroscopy may be helpful, genetic typing may be helpful. We have newer materials, and I really believe that the viscoelastic one-piece disc in some version will be a better answer than the mechanical ones. We may also find ways to protect the sacroiliac joint from our long scoliosis reconstructions, and may also help to prevent a PJK, not a lumbar disc in the thoracic, obviously, but some variation of a motion preservation. And then we may have level-specific, patient-specific implant designs, and ultimately, biologic regeneration will be the answer, as they are doing at the University of Pennsylvania at this time. So, but I have to bring this up because I know Todd's going to talk about it. He's going to say, you know, if you believe so much in artificial disc, why did you do a fusion on a famous golfer? Well, what it does, it proves the point that the three most important aspects of successful surgery are selection, selection, and selection. And the best artificial disc patients are those that have chronic functionally limiting low back pain with 1 to 2, even 3 levels degenerative disc disease, with marked limitation of activities of daily living, failed conservative treatment, not for just 6 months, but usually for years. Recurrent herniated disc patients are great candidates. They should have no litigation, no narcotics, working, no social issues, and have normal bone density and have intact facets. And besides, Todd, we're not one-trick ponies. So ADR has good long-term follow-up and does lessen radiographic ALD. It's not for all patients, and careful selection is most important. And as Bae alluded to, fusions outnumber ADRs 201 in the US, but they both provide long-term improvement. There have been no studies all throughout the world and few reports of device failure of the current designs and materials. And most importantly, we have not seen the disasters and early revisions that were predicted early on. So lumbar disc arthroplasty plays a pivotal role in spine care in 2020, and I believe is here to stay and will spawn future technology enhancing our outcomes of our complex reconstructions. Thank you.
Great, thank you, Dr. Geyer. And finishing off our presentation will be Dr. Todd Albert, who will take the opposing position that there is no role for lumbar disc arthroplasty in 2020. Dr. Albert?
You guys see my screen?
Yes.
Terrific. Well, thank you so much. I want to thank Yoshi Katsura, who was my fellow and then my partner who helped me put this together. I am honored to be with these two guys. I'm very fond of both Rick Geyer and Hyun Bae. They're wrong, but I'm fond of them. And they're a little crazy, but I'm here to provide some sense to the discussion tonight. And I would just say, there's like 67 people on this call. And I would guess that every one of them, if they were given a choice that they could take care of radiculopathy, myelopathy, or herniated disc for sciatica, they would choose that. And I would say to my fellows, if you're going to make a practice taking care of people with back pain that you can't absolutely know the pain generator, you're going to have a significant number of people sitting in your waiting room saying, the doctor tried, but he didn't help me. And that's not good for business. So I'm going to try to add a little sense to this. This is my conflicts. I do get royalties on some instrumentation I have patents on that are for fusion, but I don't get anything for anterior cages or a disc replacement for this. So the general problem is this is not a good diagnosis to operate on. And if you're going to operate on it, you want to have an endpoint that you can define. So the arguments I'll make are there's no good options for the escape from arthroplasty. It's difficult to escape from failed fusion, but certainly more doable. And I guess I would say, number one, is it worth it? I don't think there's good revision options, even though Rick just said there is. I don't think there is. I think the literature is extremely biased. And the biggest thing is if it's not successful, you're operating on something That's definitely not a guarantee. And in 6 months to a year after you pick that patient, if it doesn't work out, there's a lot more questions with disc arthroplasty. So let's start with, is it worth it? There's no good test to properly diagnose discogenic back pain and thus select the perfect patient for intervention. This has been shown. Discograms have a high false positive rate. This is an old paper, but it showed that the majority of patients with positive discograms improved with non-operative treatment. So it leaves in question, should they even get an operation? And the majority of LDR devices, as has been eloquently stated, have been withdrawn from the market. So there's really limited long-term data, though I thought Rick did a beautiful job presenting some good data, but it's from one center pretty much, from a bunch of crazy guys that like doing this operation, but it was very good data. So there's limited data. So you already heard that a majority of the devices have been recalled. There's some available in Europe, not widely available. There's usually a reason for that. And I would argue it's not only insurance. And the thing is, while they showed papers, Rick showed a lot of papers, he didn't show data. And think about it, these trials were all set up as non-inferiority. So let's compare to an operation for a bad disease and show that it's the same. What the hell is that? It's the same as a bad operation. There's never been superiority shown for a disc replacement. It's been equivocal at best. So here's a paper from Rick. I think he alluded to this paper. There was no statistical difference in clinical outcome between the groups, between a fusion and a disc replacement. His partner, Jack, showed no statistical difference in SF36, device success, or satisfaction for the ProDisc trial versus a front back fusion. And if you say, well, does it really keep its promise? Rick also showed some nice studies, but I'm not sure they were so convincing about adjacent segment disease. I think it's inconclusive at best. And here, Jim Harrop, my old partner, did a review of adjacent segment disease in lumbar disc replacement versus fusion. And he said there was no level 1 or level 2 data to support superiority for adjacent segment disease. And it was really only the lowest quality data to support improvement. And there was high bias and low consistency. And the revision rate for LDR versus fusion in this paper showed beyond 1 year, the revision rates were quite equivalent between the groups. Spontaneous ankylosis, though Rick said it doesn't happen, this paper showed that 60% of LDRs underwent spontaneous fusion by 17 years. Now, escape from fusion. Okay, Rick said that there's been very few revisions, but if you have to do a revision in these patients, not only is it not easy, it's a deadly operation. It is a deadly operation. So you have the choice. If it doesn't work out, you can do an anterior revision alone, a posterior conversion to a fusion alone, only if the implant's in acceptable position, or an anterior removal and circumferential fusion. Those are basically your choices. And a revision to anterior disc replacement to an anterior disc replacement, there's really little or no data available on the outcome for this. And as I said, revision to an anterior approach, if you go to an anterior approach, a revision anterior approach, I don't know how many people on the call have done that. I think it's one of the most difficult things you can do. You get a needle out and you start puncturing to find where the vessels are. Really dangerous. It's a deadly operation. And in McAfee's report in 2006, revision anterior LDR, there was a 16% incidence of vascular injury, and 8% of the approaches had to be aborted due to complexity. And he had a spectacular anterior surgeon. In this report, there was a 63% overall complication rate with retrieval. 24% had a second revision, 20% pseudarthrosis, 12% major vascular injuries, 4% colon injury, ureter injury, and procedure abortion. Revision to a posterior approach, there is a high likelihood of pseudarthrosis and hardware complication that's been reported. So in this report, You can see 28% had a second revision, 18% pseudoarthrosis, 10% adjacent segment disease, and 2.6% hardware complication. And revision posterior, 21% failure with posterior fusion alone. So that's not so happy of a story for the revisions. Now, to me, this is the biggest reason that I would choose not to do an LDR, though my friends are aficionados and quite discophiles in this. So if you have a patient, as I said, with this diagnosis, which is not an ideal diagnosis, and you choose to do an LDR versus an ALIF, and let's just say it doesn't work out, your question at 6 months or a year is the diagnosis correct? Is the LDR correctly positioned? Did the LDR size or height correct? Could that be the problem? Or is there facet disease that I either didn't recognize or got worse over time? And if it's an ALIF, guess what? You only have one question. Is it fused? Now, if it's fused, sorry, we missed the pain generator, which can happen. But there's not all those other questions. I'd rather ask one question than 5 questions. And I hate to say it, the literature is incredibly biased that everybody's referring to. There's been huge conflict of interest in this policy, in this thing. And listen, I have lots of conflict of interest, so I don't think it's always bad, but you have to at least nod to it. 76% of all the literature for these studies report a conflict of interest, and that's in itself not a problem. This is. The LDR studies with internal conflicts of interest were more likely to report favorable outcomes than were those without it. And you're not kidding. Rick knew it was coming, and he didn't tell you the details about Tiger's thing. But when he needed a guarantee, the most important patient he's ever taken care of, I guarantee you, in his life, what operation did he choose? I didn't see him picking a disc replacement in this famous athlete. And according to Tiger, this is right off the site. According to Tiger, he said he did a lot of research and he decided, he should be here tonight, he decided that surgery through an anterior approach is the best option. And after he decided that, he thought he had to rely on his surgeon to decide what the best operation was. So I think everybody on this call should rely on his surgeon to decide what the best operation for this problem is as well. So in summary, there are dubious indications for disc replacement. I believe there are false promises. Why would you set up studies to prove that it's non-inferior to the operation I'm talking about? I think it's high risk with no escape. There is a high risk of bias. And I would again just say, if it doesn't work out, which if you're gonna dabble in back pain surgery, there's a high risk it's not gonna work out. And you're gonna be stuck at 6 months to a year saying, did I do the wrong diagnosis? Did I position this device correctly? Was it sized correctly? Did I miss facet disease? And if you choose an ALIF, you're only gonna have one question. Is it fused? Thank you very much. I look forward to the discussion.
Great, thank you, Dr. Albert. I'd like to thank all the speakers. That was fantastic. Why don't we, there's some questions in the Q&A, but why don't I start off by asking Dr. Bae and Dr. Geyer. There's a question regarding insurance and dealing with insurance. Bae, you mentioned top three barriers were insurance denials or barriers. Any recommendations or tips or strategies in how you interact with insurance when trying to get one of these procedures improved?
Yeah, I think in these days, you have to read the policy. So whatever local policy is in whatever company that it may be, whether it's Blue Cross of California versus Blue Shield of California. Let me give you an example. For Blue Shield of California, the patients have to go through a comprehensive, what do they call it now? Comprehensive behavioral therapy program, okay? Nobody even know what that means, okay? But in your note, if you really don't say that with physical therapy, you went through a comprehensive behavioral program, they're not gonna approve it because you gotta understand who's on the other side. And the person on the other side is someone who's just looking at your note and trying to check off the boxes. So you need to know what are the boxes that you need to check off. For Blue Cross, for a long time, you actually had to say less than grade 1 spondylolisthesis to get it approved. And if the patient didn't have the word spondylolisthesis, you could not get it approved because they were going by the FDA inclusion criteria. And so you need to know what boxes to check off. And so each one is unique. Some are pretty simple, some are more complex, but if you just got to figure out, okay, who this patient is, what is this carrier, and what does the carrier require? And if you check off those boxes, it now is relatively straightforward. Rick, do you have any other experience?
Well, what you're exactly right, Bay. You have to know each one. And we used to keep a little 3-ring binder, and it was a mess. And then we finally had our IT guy incorporate it into our EMR. So when we came down to the diagnosis, we had a little box next door, and you clicked on the insurance if you wanted to see the criteria for ADR or for fusion or ACDF or whatever. It gave you all the tick points. So you'd say, and the patient is a 49-year-old with greater than 6 months of conservative treatment and no more than a grade 1 spondylolisthesis, and ODI of greater than 40, and failed injection and failed that. So you put all those tick marks because, as Bay just said, you just have a clerk on the other side. If you miss one of them, it can be agony. Now, I'll tell you another thing that can occur. I always ask the patients who they have the insurance through, because if they have to work for a big company or their spouse does and they're self-insured, you have a good chance of getting it overturned. Now, recently, a patient I'm operating on tomorrow has Aetna insurance, and they were like bulldogs. And I said, how did you get it approved? I just did a pre-op a few hours ago. She said, we did 3 appeals. So you have to get the patient involved. And there's also companies that will help you do this or help the patients do it. And the problem is it costs the insurance company thousands of dollars to navigate these appeals, and they don't like it. And if you keep on sending appeals back, it's costing them more and more money.
Similarly, along those lines, in pushing the indication for disc replacement, how much facet arthrosis will you tolerate? And how do you quantify that?
Well, I mean, it depends on the quality of the MRI scan. MRI scans are like cars. There's some really crappy ones and there's some really high quality ones where you can truly see the facets well. I used to think that if they had pain with extension, we should do facet injections. Roger Jackson years ago said that didn't have any correlation. But so if they look perfectly normal, you're fine. If they show just a little bit of cupping, maybe a little bit of narrowing, like a grade 1 or a grade 2, fine. But when they start to have bone that encompasses the facet joint, or they're really trashed out, then no. So those are like the grade 3 and grade 4s, and I don't know what Bay does, but
yeah, I think very similar. I just don't believe in facetogenic pain in normal looking facets. I think it's a lot easier to tell discogenic pain. I don't do discograms. I tell discogenic pain just by listening to the patient, making sure that, he's not taking high opiates, he's normal. You don't really need a discogram, especially when you're doing single or double level. It's quite obvious. It's not a unclear diagnosis. And then truly, if I look at the facets, and just like Rick said, if they have mild arthrosis, it doesn't even bother me. But when they start getting, a true kind of jagged kind of facet joint, or the osteophyte that surrounds a facet, then, I don't think that's worth it.
And I agree with you, Bay. Unlike Todd, you and I examine the patients and we can make the diagnosis. No, I'm kidding, Todd. but the diagnosis of discogenic back pain.
Todd just looks at the pocketbook.
I know, but the diagnosis of discogenic back pain, it is not every person that comes in with backache. I mean, these are people that give you the classic history, and they bring in their serial x-rays. You see L5, S1 start out at a certain height. They have an MRI scan from 2 or 3 years ago. You see the one from 2 years ago, and now this one is totally collapsed, and the other discs look pristine. They tell you that they can't sit, they can't stand, they have trouble getting dressed in the morning, and as you said, they're not on narcotics. They're nice people. They've given up all the things that they like to do, and they're 36 or 38 years old. I mean, so it does take skill, and I admit it. I have a very skewed population like you, Bay, and we're not seeing work comp low back pain and doing artificial disc in them. we're dealing with people that are really disabled by their back pain, and you can cure it, Todd.
Dr. Albert, how do you approach discogenic pain?
Go with a fusion. And they
Well, of course you can. But the problem is, just like I showed, how many cases have you seen where you've done a single level fusion, where you come back, you got to do another operation, another operation, another operation? We rarely see that with arthroplasty, and I'll let Bae speak up, and he's been doing them for almost as long as I have.
Well, I think when you look at the studies and they show non-equivalence, or equivalency, these are just FDA measures, right? And that's why, it's designed that way. But there is one big difference, okay? One is a fusion. That segment you've taken out. The other, you have motion. That's the biggest difference, right? I mean, that's the real difference. We're not talking about oswestry differences. I mean, and there's no superiority there. That's just really FDA criteria. The biggest difference is, and this is the reason we're doing is, hey, one has motion and one doesn't. And when you fix a segment, it does cause a cascade, So like for you, Todd, I would say, yes, you're right. If the patient comes back and says, and I know this is what Todd does, when the patient comes back and says, Doc, you've done a fusion for me. I still have pain. You've done an L5S1 fusion. Todd just says, it's got to be your 4-5 disc. We got to go back there and do another. So that's the other issue, right?
And Bae, I don't know if you found this, but some of my best patients, absolutely best ones, are the ones that had, not 1 or 2 recurrences, but 2 or 3 disc herniations, and they've been told that you need a fusion, and you can go in there, and it's like doing an ACDF. You can fish out the fragment, and those patients are my best arthroplasty patients, to be honest with you.
No,
they are the
I
happiest
agree too.
patients.
Yeah, I agree. It's pretty interesting. It's like, and I agree with Todd. Like, if you're looking at one level degenerative disc disease, modic changes, all that, 5-1. I mean, honestly, a fusion, you're going to do a fusion, the patient's going to do wonderfully, like wonderfully, especially if you don't have to go at a posterior approach. So these standalone devices, I love them because avoiding that posterior approach, I mean, you never know what's going to happen. You put pedicle screws percutaneously, it just adds another level of, I would say, uncertainty. So I love the fact that you can do anterior approaches. So if you can do, ALIF with some type of screw-based design, and that's an amazing operation. And you can get away with either. I just, and this is kind of what I see is like, I start seeing cases where I'm like, it's challenging. Like you get a patient that already has adjacent level disease, right? Or, you get a patient who, like that patient who maybe has a 5-1 fusion and it's not adjacent level, it's 3-4 that comes back, that has a problem, right? And then you're saying to yourself, oh gosh, what do I do here? Do I do a fusion at 3-4 and then fuse from 4-5 segment? Do I do 2 isolated fusions? And so, I think in those cases, that's where I see the indications hopefully kind of expanding in the future, where, I think in that case, it's a big difference. Or if you're looking from 4-1 disease, I hesitate against doing a 2-level standalone L4 to S1 if I need to fuse a patient from 4-1. Let's say they have a spondy at 4-5, and let's say just disc degeneration of 5-1. And if you're trying to treat that, you may say, oh gosh, I'm going to have to do a 4-1 fusion. I'm going to put pedicle screws in the back, because I wouldn't do that in the anterior approach, especially if it's 2 levels. And so sometimes in these cases, if the spondy is really not so translational, you can do an anterior approach only. You can do a 4-5 fusion at the spondy level, do an indirect decompression, and then just do a 5-1 ADR. And I think that's an elegant way of trying to decrease the morbidity for the patient. You know what I'm saying? Where you don't have to go in the back. So, there are cases like that where I think that, we may see, I'd like the utilization of artificial discs. It's gotten me out of some difficult jams.
Yeah, Bae, and I think that's a perfect indication is for transition disease. And I've done a lot of patients that have had, single level fusions at L5S1 that either they didn't have an anterior approach or they had an anterior approach, but we have really good access surgeons, and we could still get into 4-5 and do the artificial disc there. And the case that you just pointed out, I did an artificial disc on a patient about 8 years ago at L5S1, and he came back about a year ago, was complaining of more back pain, but a little bit higher up, and L3-4 we could see was progressively degenerating. So we carried him along until he finally couldn't stand it. So we tried to get the L3-4 level approved, and the insurance company says, well, it's only approved for a single level. And I said, no, I said, actually, you just got approved for 2 level. And he said, would you consider doing a fusion? I said, I can't convince this patient to have a fusion because they had an artificial disc for 8 years and did so well. He doesn't want a fusion. So finally they approved it. So L5S1
Great.
skip level, and then now I'm going to do 3-4.
Yeah, so I think it's these cases I think that we'll see in the future that may convince Todd, so that these challenging cases where you look at them and you're like, oh my gosh, I may have to fuse a level that I really don't want to fuse, or when you're just following the cascade and you're thinking, gosh, I wish I had something different.
Well, I have the advantage of doing 80 to 90% cervical spine. So I operate on patients that get better, which is very nice.
You know what, Todd? That's why I couldn't find anything on you about Google, about lumbar disc.
Do you do cervical artificial disc?
Oh, I love it. Yes.
See?
For the right pay, I love it. I'm not against artificial disc.
Yeah.
I'm against
it's just.
I want you to look in the chat room at John Heller's little comment to you guys. You see it? I can read it to you. Rick,
okay, no, I see it. Okay.
Can
Well,
you
of course,
read
I mean,
that patient's fine. They're women.
In other words, he's saying our revisions go back home, and we. You know what? We actually are. We're doing a follow-up of our entire lumbar disc population, and we're calling them. I think we have. Like 2,500, we're up to about 750 follow-ups. This is from when we first started. So maybe some of them will be honest and tell us if they had more surgery.
No, it's great. I commend you for doing it because that's what really needs to be done.
Well, power's in the data. You know that, Todd.
Absolutely. But not to be, I mean, we all know that there's a tremendous amount of revision surgery related to fusions, but we just accept that because it's just in our, it's kind of ingrained in us, right? And I'm not even talking about well-done fusions that have adjacent level of PJK issues. I'm talking about, the revisions that we see that a misplaced cage migration, misplaced pedicle screw, pseudoarthrosis, so on and so forth. But, I think, we all accept those because they kind of go with the territory. And there's going to be some, not every artificial disc is going to work out well. And, I do see your point that, hey, revisions can be more difficult, but as you get used to them, I will tell you a revision of a misplaced cage is also very difficult, but you get used to it, right? You develop an expertise. And I think as the field develops and evolves, there'll be a lot more people with the expertise to revise artificial disc. And that's what Rick is kind of saying. Like when you start having to do them with an experienced vascular surgeon who's done artificial disc, it's not as, daunting and crazy, as, it may seem.
But I do think, and Bae, your talk was very sobering because it is the truth. And, when I started looking at the numbers, I was trying to get from the companies how many discs were done. And that's how I came up with the, 200 to 1 because 400,000 fusions and about 100,000 artificial discs per year. There's not a whole lot or not 100,000 at 2,000. So
yeah, that makes more sense.
Yeah. So it is very sobering, but the technology in some different form, I think will be applicable even to our long, reconstructions and the thoracolumbar spine. And I'm not saying they're going to look like what we have today, but I know everybody's going crazy. Izzy Liebman from my group, he's in the study group for the bedrock procedure, the old Flintstones going down to the sacrum. Sure. And it doesn't make sense. I mean, I think that in 20 years, we're going to look back. Maybe I won't, but the younger folks will look back and say, "Oh my God, I can't believe you put metal from T7 down to all the way to the sacrum, and look what we can do now." I mean, there'll be some type of motion preservation, some better way that we do it than just fusions. And I'm not saying they're not good, Todd, and the work that the deformity surgeons do are fantastic, but there's got to be a better way sometime in the future.
Yeah, I think, before we were doing PI-LL mismatch, and now we're talking about harmonious, spinal alignment, PI-LL, you can't use one. So there's always a new angle, there's always a new focus, and there was a time when we would say, we thought if you fuse a patient and gave the patient a hyperlordotic cage, the patient wouldn't come back with adjacent level issues. And I think it's really missing the point. The biggest impact to adjacent level disease is not a 3-degree difference in lordosis. The biggest impact, the effect size of adjacent level disease, is the fact that you took a disc and you fused it. That is the biggest impact, regardless of lordosis, or regardless of position.
You may be ignoring genetics as well. Genetics, please.
Yeah,
Yeah,
absolutely.
genetics is a big deal. You're exactly right,
Absolutely.
Todd.
Yeah.
All right, so why don't we,
No matter what lordosis you have, it's never going to fix PJK, right? If you're going to fuse from T10 to the pelvis, I mean, no matter what, or AI, or whatever you have, or whatever you're going to program, at the end of the day, if you're going to physiologically fuse that many segments, you're always going to have PJK. You know, maybe you can reduce the rate a little bit, but you know, it's impossible not to have it. You're fighting gravity, you're fighting aging, you got a stiff segment. It's almost impossible not to have it.
Fantastic. Thank you all. It's a little after 8 o'clock right now, but why don't we just end with a quick roundtable one-liner. What's the future for disc replacement 5-10 years from now? Are we still going to be debating it just like we did in 2006, or will it kind of declare itself one way or the other? Start off with you, Dr. Albert.
I don't know that we'll still be debating it. I think there will be a subsect of rebels like my partners on the call that will, I don't know that we'll be debating it.
Hey.
I love that. I would say 5 years. I don't see it much changing. I do think in 10 years we will see more hybrid approaches. You know, people will start thinking long constructs. They'll say, hey, how do I divide this? What can I do to avoid this? I do think that usage in 10 years, we may have discs that are not as flexible, but just not our fusions, right? So, you know, that may be another segment that we kind of create in the future.
Last word, Rick.
Well, you know, I hope that we'll have more advanced discs, but unfortunately right now we don't have any in the pipeline, and that's a sad part. I agree with Bae. I think, you know, for the early time, we're going to see expanded usage and application form, you know, used for adjacent segment disease and used for recurrent herniated disc. But it is kind of sad because it's a technology that I think is beneficial. It's not for a huge number of people, but we'll see.
Yeah, I agree with that.